I will now, the plan for me is a bit to start with photon therapy. Yeah, I mean, we are at a hadron therapy symposium, but we should also, when we discuss this, not forget that all of this research on the medical physics side, at least, comes from photon therapy, because photon therapy is the by far dominant mechanism of treating compared to ions. Yeah, like protons are getting more and more common. Ions are very uncommon, like heavier ions like helium or carbon. I think helium is just was commissioned just in Heidelberg to use for patient treatment, and that's kind of one facility. I think the Japanese can do helium treatments clinically now as well. But these are basically 2 facilities or 3 facilities compared to the whole rest. Of course, it's an extremely exciting thing, so that's why we're here, but we need to know where we're coming from and why it is exciting, apart from the obvious physics reasons why ion therapy and therapy with particles is exciting. So we start with photons. We will look at how photons work, why we need multiple beams, and so on and so on. And then we will see what happens when we switch to particles, like to charged particles. I know I'm switching a bit. I'm a little bit more freestyling the nomenclature, because sometimes there's like some communities calling it hadron therapy, because there have also been some irradiations in the past, for example, with mesons, yeah, not only the baryons we know. So, but some call it just particle therapy and kind of forget that photons are also particles in a sense. And some call it ions, but then you basically discard the neutrons. So you see like there's a little bit of a nomenclature issue here. And I just kind of freestyle it and use all of them during my time. But what we do here, or what we work with today, are, I think, the best summarizing term and also specifying it as ions. Yeah, we have protons as hydrogen ions, we have carbon ions, and helium I can show you at the end. Okay, good. So if you go on this agenda website here, there was now I have to figure out a timetable, was it? No, it was on the timetable, right? Yeah. No, it was not on the timetable. I'm looking for something else. I've had the website open before.
What are you looking for?
I think it was the agenda, yes. So there were some workflows already shown, like 3 workflows that we in some way or another did in past schools. We will follow them loosely. You can always follow them exactly if you're interested. Yeah, you can open them as PDFs, for example, here. And it takes you very detailed through a nice workflow. For example, here you just set up photon plans and then switch to protons, and also try to do some realistic patient case. I still have to say this is a very mean setup that I chose here. It's very difficult to achieve this, but I think very few students work hard and long enough to get close to the clinical prescriptions here. But just shows you that treatment planning is really not that easy sometimes. Okay, so these workflows are kind of interesting. I will follow them loosely, try to do something similar, but I will not do it in this detail because we have a lot of participants. If something doesn't work, it doesn't make sense to kind of wait for 20 minutes for people to try to get a nice treatment plan, or even longer. So we will do it a little bit more loosely, so that everybody has something to look at and to follow. Okay, so but that's the idea. First, a little bit of photon planning and then transitioning to protons. And we will start with very simple water-like phantoms. I always call them like rectangular alien patients. Yeah, we start with this. And I will switch a little bit also to presentations that show a little bit of technical details of what's going on, like in the meantime. So you have a little bit, on the one hand, you see what's happening in the user interface, you see dose distributions forming, and you can look at dose distributions. Then we will look a little bit about how the data is handled, what's happening in the background, and we will look at also maybe one or two formulas that try to describe what is going on. So now let me quickly think about where to start with. I think I will start a little bit with some introduction. So because in the previous, not in the previous, like in the medical physics view on treatment planning, there were a little bit interesting things said. Let me start from here with some slides. So he already explained that we have these contours and we contour organs at risk and whatsoever. So we usually, this would be for some treatment near the brainstem. So you see a head CT scan. You see, for example, the eyes delineated with contours. This is usually work done by people still, yeah. So kind of really delineating the organs, that's done slice by people. Of course, this is like a task that is heavily challenged by AI right now. Yeah. So more and more systems, especially when vendors now try to kind of conquer the adaptive treatment market where things need to go fast. So adaptive treatment means you're really trying to correct for all the changes you see on the table. Yeah, classical treatments are usually you take a scan, you prepare the plan while the patient is home, away, do all these things, patient comes, you do the positioning and you try to irradiate. But in an adaptive environment, you would also try for any anatomy change, to correct for any anatomy change and whatsoever as good as possible. And there you need to be really fast, you need to redelineate and whatsoever. And then AI plays a big role now. So this is like one of these nice, well-defined tasks for which, for example, UNets or convolutional neural networks in general are quite good. They kind of can be trained on a lot of segmented patient data to predict the contours. So that's like one of the tasks that I think will be soon very, very well automated. And I probably speak for anybody involved in this that having organs at risk contoured by an AI would take so much of the workload away. If you just would need to give it one look, this was done correctly here, maybe a correction, like there are already studies that this can really free so many resources. Yeah, you have all these, oops, sorry. Let me try to use the pointer again. These contours here, of course, this might be supported by MR images. And in this case, you have a tumor directly next to the brainstem and the chiasm, which is this thing connected to the optic nerves, like kind of processing input from the eyes. So that's a very dangerous treatment in a sense. Yeah, you have two very important, very sensitive organs at risk next to your tumor that kind of hurting them or like having radiation damage to them can be like really serious for the patient, result in blindness or something like that. So very difficult treatment, but kind of that's what you do. You delineate. And I always, yeah, like I always like to try to get a little bit back to the mathematical thinking of the problem then. So let's say from this very complex treatment, we simplify this a little bit and go to a very simple treatment. Yeah, and as I said, we're using these water phantoms. And in these water phantoms, I said, like these, you can interpret this as a very alien-like patient with this rectangular water body. And the patient only has one organ, it's this green one in the middle, but unfortunately around this organ, a very symmetrical C-shaped tumor grew. Yeah. The red one is a target, a planning target volume. This is an organ, and this is a box, like the body of the patient. And it's lying on a table. In radiation therapy, we always use these, or almost always use these very flat tables, very uncomfortable. And usually on the table, there might be some, maybe you have like some support for the legs, or maybe some compression mat to kind of keep your body in shape, all for positioning. But that's kind of usually what you lie on. And so now we want to irradiate this tumor. And I always like to go back to how a mathematician would think about this problem. Like if you tell them, please irradiate the tumor and spare the rest of the tissue, what would be your ideal dose distribution? And if you ask this a mathematician, they probably would say something like this. Yeah, I want to have my perfect prescribed dose in the tumor, so that's now red, and everything else is 0. Right? Like that's the mathematical ideal dose distribution. If you're a physicist, you then say, yeah, good luck achieving that. You understand something about scattering and that radiation has to pass through matter. Yeah. So we need to kind of figure out a way to approximate this ideal dose distribution. And the things we have for this, and I said we start with photons. We are in a hospital that doesn't have an ion facility, as most of the hospitals in the world. So we have a photon beam and we have a collimator. That's like the two things you have from the practical side of view. So we basically went from engineer, from mathematician to engineer now. The engineer has now a photon beam and a collimator. And you tell them, please create a C-shaped, like I imagine this discussion between the mathematician and the engineer. Like, here's like this dose I want to have, and you have this, and now good luck. So how do we get there? And the first idea, like involving the physicist, the physicist tells you, okay, if you have this, this is what the dose looks like. Yeah, and then you can just try to irradiate this. And of course, if you start with doing this, this looks nothing like something that irradiates the C. Like the patient got a little bit rounder here, but shouldn't matter. This photon beam, of course, like this decreasing dose and depth, does not help you at all in irradiating this tumor and sparing the rest of the tissue. The maximum dose is in the completely wrong spot. And basically here, there's kind of no differentiation between the target region or anything else. A little bit of collimation has been going on. So this is like really just two, like a physicist, an engineer, and a mathematician with some clinical guidance on what to do in the tumor, trying to solve the problem. Okay, but then the engineer says, wait a minute. I can just use multiple of these beams, like a little bit experimental applied approach. So I just stack them on top of each other and always collimate them, because I can move the collimator leaves. We saw these nice images for the breast plan. And I stick them together and look at this, really nice. So I have now all my radiation dose in the target region. And then they are for a minute happy, and then the clinician comes again, but and said, yeah, okay, but do you want to kill this organ completely, because there's dose in the organ as well. Yeah, so basically, this kind of treatments are the ones that have been done for a long time. Yeah, and the mathematician then says, yeah, okay, but maybe for every convex tumor, this looks nice. If there's no C shape in here, or we do not wrap our tumor around something, then this works quite well. I just put open fields and stack them on top of each other. But as soon as I have some weird shapes, this does not seem to work again. Okay, so now what do the physicists, mathematician, engineer need? Maybe an applied mathematician or operations researcher that tells them a little bit about to ask a computer of how to shape a dose. And so when all of these minds come together, you basically start to figure out some solutions of how to challenge this problem. If you would not be limited, like to just using the shape of the tumor, if you could basically use any shape in this collimator, you can kind of start to modulate your fields. But how do you do that? So the idea one came up with is to basically divide your field into very small parts of the field. Yeah. Okay. So basically, what you do is you create very tiny beamlets, or you think about these very tiny beamlets. You do not create them. You just basically artificially think of these very tiny beamlets that you could irradiate. And all of these tiny beamlets, sorry, like I thought there was another thing, is all these tiny beamlets together create the open field. Yeah. If all of these are irradiated, they together form a nice open beam. Yeah. So this tiny beamlet doesn't yet exist. It's just like one sub-region of the big beam you are looking at. And then you calculate, we heard about the algorithms, I won't repeat that. But what this helps, yeah, here, kind of you see, if I add them together, I have a homogeneous beam, but I can also give them, here, don't read this, look at this, I can give them different weights. Like if one beamlet, one region is more important than the other, or one needs more spared, I can just change the weight of this individual beamlet. I basically look at my beam, these are all the beamlets, and I give them different intensities. So this beamlet, I don't know if white or black here is supposed to be larger, but this beamlet might need more intensity, and this might need none at all. So they do not exist yet. They just exist in your description of the problem. We like to call these beamlets pixels for pixel and beamlet. And then, for example, I can create artificial beams where certain regions are less dosed or more dosed than the others. So this is a concept. It's a concept to think about. The problem is now creating this is, of course, what you could do. You could take a collimator, put it to a very tiny region, and then do this one by one, but this would be very inefficient. So this is at the moment just a concept, but you can think about an arbitrary intensity for a beam. Yeah. And if you make enough of these tiny beamlets and choose a large enough number of beams, you get a large number of degrees of freedom. Yeah, so have thousands of tiny beams in your treatment that you could now start to modulate theoretically, but cannot do this by hand. Like you cannot choose 1,000 variables by hand. Like you could try, but good luck. We see each other again in 10 years when you have solved the problem. So what we do is that we need an optimization step. And this optimization step decides these weights for us. And now we have the problem that, again, we are basically like working on this implementation problem. I'm an engineer, a mathematician, and a physicist. And we need to figure out what the clinicians want out of this. So we need a way to encode what the clinician wants into a function. Yeah. So that's something we understand as physicists. I understand a function. It's difficult to sometimes understand not only doctor's handwriting, but we come up with functions that describe something. So if we want to have a homogeneous dose in a target, then we can describe how close we are to this dose by computing the quadratic difference in all image points to this dose. Right? Makes sense. Like if this is my dose that I want, and this is the dose, the eye basically tells me every image point, every voxel in the patient CT, and if the dose in every voxel is the same as the dose I want, then this whole function is 0. If it's different, I get a positive value. Yeah? And the far further away I am from that, the worse I am in my dose. And I can write different functions. For example, I could just say, I want to have minimal mean dose. I just have a function that basically gives me the mean. And if the mean dose is 0, then this function is 0. Yeah. And the same, like there are more complicated functions where I only want to have positive or negative differences. In reality, there's tons of these functions in a treatment planning system. So you have some that directly work on dose volume histograms that you saw earlier. You have some that try to encode some biological information, like is the organ serially damageable. So for example, the spinal cord is a serial organ. If you hurt kind of one part, it kind of translates to everything below. And while the liver, for example, is a kind of parallel organ. The liver you can kind of take out a part and it still works, not in full capacity, but it still works. And they're like functions to encode all of these clinical and biological ideas. Some of them are good, some of them are a little bit more approximate, like some biology and clinical decision makings. We cannot approximate that well with physics. Yeah, okay, but we try. But this is kind of, we have tons of these functions. And when all these functions have their best value clinically at 0 and are basically positive otherwise, we just need to try to minimize them. And then basically the clinician, the physicist, the mathematician, and the engineer that we talked about, they go to an operations researcher, which is probably also a computer science engineer of some point, and ask them, okay, please minimize this function. I have a lot of variables in this. I have a lot of image points, and like I have thousands of beamlet variables. Please come up with something. They tell you about, for example, Newton's method, a little bit simplified now. The optimizers used for this are a little bit challenging. They say I have some methods, right, to walk down a function numerically that has a lot of variables. And so they do optimization. And what you usually do in optimization algorithms, like you just kind of evaluate, you start on some point, calculate your function. Often you use the derivative, then step in some direction and find a point that is closer. So in this example, we would have two beams, two beamlets, one and the other one. And kind of our optimal plan lies somewhere here. So we would continuously walk to this point. Then basically the operations researchers say, I found a solution. You need to take one beamlet, like apply an intensity of 5, and then you need to take another one and apply an intensity of -1. And then you basically think about a physicist, then the physicist comes in, like the mathematician is also happy, but the physicist says, yeah, okay, if you tell me how to create a negative dose, I help you. So you need to basically hear the physicist again to say, maybe the realistic solution lies here, only dose from beamlet number 2. Okay? And if we combine all of this, we can start to create doses like this. Yeah. So basically an optimizer decided now where to put in higher doses. Like for example, this beam has some high dose contributions here and takes out the dose that is in the middle. This beam is a little bit lower in general contributions as this beam, and so on and so on. So these fields here, they look somewhat simple. Yeah, you could also think a bit, it makes sense as a human, you could think it makes sense that there is a little bit less dose from these regions. So you might have come up with this also without an operations research engineer. But if the shapes become more complicated, there's no way to determine this by hand. So everybody's happy now, and we know how to make treatment plans. We need this beamlet concept, have these doses of these individual beamlets. We will actually never create these beamlets in practice. We will use a sequencing algorithm. We will look at this later. Plan, optimize the dose according to some like mathematical formulation of the clinical problem, and get like our treatment. And this form of treatment, like this intensity modulation, is something that works for photons, protons, other ions, hadrons, whatsoever, almost in the same way, except for that for protons and ions, especially how they are used now, like basically where you have basically point a very sharp beam at an individual location, there you really have these beam elements as kind of individual spots. But we can also discuss this a bit later. But this was really a huge revolution in photon treatment planning that started in the 90s. The next revolution was these rotating arcs, I would say. But this kind of changed what we can treat and the toxicity, like minimizing the toxicity of treatments hugely, and kind of had impact for, like, I don't know, millions of cancer patients, because you could do this with a Linac that has a collimator, right? You didn't need a new machine, you just needed some newer software and create these plans. Yeah, as said, in the practice, there are tons of these functions, and you put them into an optimization problem. And let's go to the ions a little bit later. Let's try to do this now and hands-on. Let's take a look at this. How does this work in a treatment planning system? So I told you how to install matRad. Like some of you might now have installed it as an executable, yeah, and started it. You will see this. Okay, you will see basically now this interface. There's nothing loaded whatsoever. So this is the state where we start. If you have this up, then you are set. If there's any error before this in the installation, as said, it might be very difficult to help you right now. And if we would help you, it would be at the cost of the other people who have it running. So we might like be sorry for that. But if you had MATLAB installed, like you have MATLAB as an environment and you have the source code of matRad, what you need to do is you need to just type matRad GUI, so matRad graphical user interface. It basically will, if you start typing it and then hit tab, it will also suggest you everything. So you can find it like this and start this. I think this, do I have, which one do I have started here? I think that's, yeah, that's the one from MATLAB. I will use MATLAB directly because I can show you what's going on in the background. Okay, so we start from this here.
Niklas, sorry, just a reminder for the on-site participants, if they need something, they can raise their hands, and we have people from Sarajevo, thanks for this, that they can also help you. Sorry, Niklas.
Yes. Yeah, so if the on-site people, they can also, you can also go through the workflows with me. So I know it's a little bit difficult, especially for online participants, to kind of, if you do not have like the gamer setup with 3 screens at home or on your workspace, you might have a little bit of difficult time to switch between the screen and your own kind of MATLAB window, look at what I'm doing and what you are doing. So if like I'm getting way too fast, that's also something you can tell, and then I try to maybe repeat a step. So that's kind of the MATLAB user interface. I will go a little bit through it. It's a little bit simplified compared to a clinical system, but you have a little bit something that takes you through the workflow. Yeah. So basically there's some refresh button here that's a little bit out of workflow, but the first step is always to load data. Then we set up the geometry and calculate the dose of our beamlets for planning. Then we go to optimization, or if we already have some optimized plan and changed some parameters, we could recalculate the dose. These wordings you see, directly see, it's a research software. These are like names that we are familiar with, but probably nobody else, like Calculate Inference MX. But I will tell you what it means later. And then you have also, of course, some export functionality. So very sensible workflow, load data, create those, optimize those, write. Yeah, so export. Your treatment plans will be configured in here, in this plan widget. this is a little bit like, it's at the same time easy and confusing to use. So basically you can just type in everything in these boxes you want. So if you want to have multiple angles, we will see this later, you just write several numbers after each other. Then you can switch between the radiation modes, like which means photons, protons, carbon ions. You can choose a machine, which you shouldn't do today. This is basically if you are a researcher and want to implement your own machine into matRad, you might make use of this. Otherwise, you today get generic machines. Generic machines mean, for example, for proton and ions, they are not kind of mimicking a specific accelerator. So they are just like kind of something that is usually or relates to an accelerator. So it will have a sensible, physically realistic description, but the machine itself does not exist. For the photons, that's true in principle, but actually the generic machine is based on a somewhat older linear accelerator used for treatments. It was a Siemens Artist, I think so. It's a little bit older model now. And this, I think, yeah, the generic machine has a 6 megavolt Linux. So that's the X-ray spectrum you will then, or gamma spectrum, as we call it, gamma X-ray. That's again nomenclature. So that's kind of the spectrum you will have. 6 MV Bremsstrahlungs spectrum.